afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and joining me today for our conversation is Dr. Kyle Planchard with the Orthopedic Clinic, and thanks for joining us, Doc.
Thanks for having me. Happy to be here.
Absolutely. Okay, so you work with the Orthopedic Clinic, and you are also an orthopedic surgeon, correct?
Correct, yes,
Yeah.
I do surgery.
Awesome. But you have, I feel like a lot of times orthopedic surgeons, you kind of specialize in different things. So what would you say is your specialty?
Yeah, that's absolutely correct. My specialty is sports medicine. I did
Okay.
a 5-year orthopedic residency at Ochsner in New Orleans, and then a 1-year subspecialty training in sports medicine in Birmingham with the Andrews Clinic there.
Nice.
So sports medicine is kind of an interesting term because it makes you think that I'd only be taking care of athletes
Right.
and that whole thing, and certainly had a lot of experience with high school athletes, college athletes, some pro athletes that came through that center. But sports medicine also, there's a lot of overlap with injuries that are middle-aged and weekend warriors and even elderly patients kind of interact with. Tendon injuries, figuring out how to fix a tendon injury and things like that. So there's a broad range of people I might talk to in clinic.
Absolutely, yeah. I feel like that is probably a misconception. Like you hear sports medicine, and you're like, oh, well, I'm out of that bracket of people that you can, help. So, but like you said, it can really affect anyone, especially if you're wanting to start a new activity. It's the new year. It's still January, so I'm sure a lot of people are trying new exercises, and like you said, weekend warriors, maybe preparing for 5Ks or things like that. So you can definitely help with those types of people. Yeah,
absolutely. I think the highest level athletes who kind of get tackled and get bent backwards, some weird awkward injury, they're going to find an injury. But also some of us, myself included, who haven't been going to the gym quite as often, some lower level activities could be more than our tendons can stand, and sometimes that can lead to an injury.
Absolutely. Okay, so but today specifically, we're kind of talking about a specific topic within orthopedics, or within maybe even sports medicine too, but rotator cuff repair or management of rotator cuff tears, which is actually something that's pretty common.
Correct. As we were kind of talking about before, rotator cuff tears are something that everyone's heard of, but maybe some people have a deeper understanding, and some people might not really know what the rotator cuff is. But it's probably the most common shoulder injury after age 40 or so. When you're younger, you're more likely to tear your labrum. You're more likely to maybe have some very specific shoulder dislocation event that you get an injury and it injures other structures. The rotator cuff could be involved in one of those situations, but the reason the rotator cuff is so commonly injured in older patients is that while it has some traumatic opportunities to tear, the wrong kind of force gets applied to it, it can also just tear with age. It can kind of a wear and tear kind of thing, so it ends up affecting a lot of people later in life.
Absolutely, yeah, and you mentioned there's a good chance that everyone knows someone or is the person that has received like the rotator cuff tear or the surgery. I can think right now of 2 people that I know that have had the surgery, so very common indeed. And so today we want to maybe talk about first, how do we prevent tearing our rotator cuff? And then obviously you are someone that someone would come to if they tear their rotator cuff.
Yeah, so the first thing you want to do is avoid aging. If you can stay about 20 years old, you will probably not tear your rotator cuff. But other than that, general healthy lifestyle practices, there's an association with rotator cuff tears and with some medical comorbidities such as diabetes, some lifestyle decisions such as smoking is not particularly good for the rotator cuff. Additionally, keeping the muscles of the rotator cuff strong can go a long way. And so physical therapy, sometimes that we do therapy for people who show up with a problem, but the same types of ideas of strengthening the little muscles around your shoulder, the periscapular stabilizers, having good posture, all the muscles that kind of we neglect when we're sitting in a chair all day, kind of those back muscles are all around the rotator cuff and can help putting so much responsibility on it that it can tear.
Yeah.
But also there's some things that we don't understand about the rotator cuff, and I don't know that we can do a perfect job of preventing it.
Right, yeah. And the rotator cuff is kind of interesting because it's not like one specific thing, it's a combination, right? Can you
Right.
explain maybe the anatomy of it?
Right. Yeah, so the term cuff, it's kind of this sheet of tissue that goes around the shoulder. It's kind of the deeper muscles under some of the more superficial muscles, like our deltoid is out here, is the first thing you would see in your shoulder as far as muscles go. But if you peel that back, there's 4 muscles that make up the rotator cuff. And so these muscles become tendons, and tendons attach muscle to bone. And so when we talk about a tear of the rotator cuff, we're talking about one of those 4 muscles, either the supraspinatus, the infraspinatus, the subscapularis, or the teres minor. One of those muscles, tendinous insertion onto the bone, has torn partially or completely, varying degrees of how torn it could be. And so those 4 muscles and varying frequencies amongst those 4 tear, and that's what we would call a rotator cuff tear.
Gotcha. Okay, so it's kind of more complicated than just like a tear. It could be maybe impacting one of those 4 things, a part of the rotator cuff, right?
Yeah, absolutely. Well, that's 100% correct to say that it could be more than a tear, because exactly anything impacting those different muscles, from kind of just inflammation of the tendons themselves, you might be able to look at them surgically or on MRI and say that is perfectly intact, there's nothing torn about it, but the tendon itself could be a little unhealthy, and that's called tendinosis. And that can happen to any tendon in the body, and that can be painful.
Right.
Also, there's a layer on top of these muscles and tendons. It's called a bursa, and it's kind of a lubricant cushion layer that also exists over a lot of tendons in our body. But that bursa can get inflamed, and so it's kind of like a tendinitis type picture. So it's not one of these big tears we might see, but it's a reason for pain.
Right, okay. Well, we have our first caller. Gladys, thanks for joining us. And what is your question for Dr. Planchard?
Oh, thank you for taking my call. I'm calling to ask, how do you diagnose the rotator cuff tear?
That's a
How is
great
it diagnosed?
That's a great question, Gladys. Thanks for asking. Yeah, so it starts with someone showing up and saying that they have shoulder pain. So you start to localize in on that. And then you kind of want to know where it hurts and what kind of things are bothersome to that patient. And so usually people are going to say that the pain is over here. They'll point vaguely to the side of their shoulder. A lot of times it'll even radiate down the arm a little bit. It doesn't have to stay right at the shoulder level, but usually not past the elbow. That's the first clue that someone might be dealing with a rotator cuff tear. A lot of times they have pain with overhead activities. They'll say, I'm good down here, I'm good, I can lift heavy things at my waist, but it's really when they try to lift things away from their body, or even lifting their arm up itself can be pretty painful. A lot of times people will complain about pain at night, and it kind of gets into laying on the side of the shoulder. They'll say that they have to sleep on the other shoulder, or they can't sleep at all. So those are some of the clues that someone might have a rotator cuff problem, as far as that less traumatic example. The more traumatic example is someone falls, or God forbid gets assaulted. I've seen that, traumatic, weird positions that their arm can get in, and they go from a totally functional arm to they walk in and they just can't lift their arm up at all. And so all of those would be part of making the diagnosis, but then the next step ultimately would be to get an MRI, and then you can see whether the rotator cuff is intact or not.
Oh, this may be the wrong question, but I'll ask it anyway because I just don't know. Can you get a tear in the hip?
Yeah, absolutely. The hip, a lot of times with age, the whole hip can wear out, and it's more of an arthritic process where the cartilage is wearing down, but there's also other soft tissue structures in the hip. When we think about tearing anything, we're usually talking about tendons or ligaments or things like that, and the hip has many muscles and tendinous attachments that come in and attach to it, and there's also a structure called the labrum in the hip that can tear, and so there's a variety of things that can tear in the hip.
And what is the treatment for it?
It would depend on the specific structure in the hip. For the labrum, if it's a clean tear of the labrum and the rest of the hip's doing well, you could consider arthroscopic labral repair. One of the more common muscle tendons to come in and attach to the area of the hip is called the gluteus medius. That can be treated with if that were to tear, that can be treated with steroid injections, physical therapy, giving it more time. If it's something that's been bothering you for 2 weeks, we might not need to jump to thinking about surgery. Maybe it'll be better in 2 months. But there's a course for all of those things where you could get an MRI and see if it's something that needs to be repaired.
Oh, just a plain X-ray wouldn't diagnose the tear. It needs to be an MRI.
That's correct. If we're talking about tears, we're typically talking about soft tissue structures, and that's where MRIs come in. We're always going to start with X-rays because we want to see if it looks like some massive arthritic picture where the X-ray could tell us if it's arthritis, and in that situation, we'd be more likely in the hip to be talking about hip replacement as a surgery, and in the shoulder probably be talking about shoulder replacement versus, which are bigger surgeries and are good surgeries for arthritis and those kinds of problems. But if we're talking about some kind of tear in the hip or some kind of rotator cuff tear, it probably requires an MRI beyond just X-ray.
All right. Thank you very much. You've been very helpful.
Absolutely.
Thanks, Gladys, for joining us and for your question. Now, if you have a question and you're just joining us, we are talking with Dr. Kyle Planchard with the Orthopedic Clinic, and give us a call at 318-219-4569. And we do have another caller. What was the name? Creighton, thanks for joining us. Clayton, thanks for joining us, and what's your question?
I was asking, cause, they were talking about the rotator cuff tear, and I recently had both of mine repaired, and it's like a 2-part question. Can arthritis cause your rotator cuff to tear? That's my first question.
That's a really good question. Arthritis usually does not cause the rotator cuff to tear, but the exact opposite is true. A massive rotator cuff tear can lead to arthritis, and so. Sorry, I don't know if you want me to talk more about that since it's not what you asked, but rotator cuff tears can lead to arthritis. And fixing a rotator cuff tear will not fix a person's arthritis, even though it could prevent a person's progression to arthritis if they haven't developed arthritis yet.
Yeah, I was asking that because they try to tell me that I don't have arthritis, but every time I move, my bones is popping and I have a lot of stiffness.
Yeah. Did they tell you did they describe your rotator cuff tear? Did they act like it was smaller, partial, or full thickness, massive? Did they give you any sense of what they were dealing with in there?
Yeah, massive. Did you give any sense of what they were dealing with there?
No, but when I look at my MRI papers, my pictures from my MRI, one of my rotator cuffs was nearly torn all the way through.
Okay. Yeah, so, and then the other part of how far out from surgery are you?
Yeah, so, and then the other part, how far out from surgery are you?
Well, I had both. My first surgery was January the 10th. And my second surgery was September the 11th.
Yeah, so the closer to surgery you are, it's never surprising to have some amount of popping in the shoulder. The rotator cuff, when it tears, you're weaker because you have a certain amount of muscle that's not attached to bone, and then after the surgery, they normally immobilize you for a while, and you don't get to do a lot. You're in a sling. It's kind of tough. You don't get to use that arm very much, and so from that time that they kind of release you to start doing things, normally you're pretty weak at that point. And anytime you're weak and you're using other muscles to move your shoulder around, it is very common for there to be some popping just because of the different biomechanics of the way you're moving your shoulder. But certainly it sounds like maybe there's some complexity to what you're dealing with, and might recommend continue to chat about that with your surgeon if you're still needing some help.
Yeah, okay. Thank you so much.
Absolutely. I hope you do well.
Awesome. Yes. Thanks, Clayton, for your call. And we have those phone lines open. As a reminder, just give us a call, 318-219-4569. We're talking with orthopedic surgeon Dr. Planchard with the Orthopedic Clinic. And Gerald, thanks for joining us. What's your question?
My question is, tell me about gout in the hand.
Yeah. Gout in the hand is very painful. It's a deposition of crystals, really. It's related to people who have high uric acid. And so they have a lot of things that they have discovered or feel that are related to high uric acid, but those are basically all the good things in life. Think cheese, meat,
Beer,
sugar.
Red meat.
Yeah, probably if you discover something else that's fun, it raises your uric acid. And so they have some medications that can lower your uric acid and decrease this kind of crystal deposits in various parts of the body. People get in their feet, their toes, their hands. And so it's painful for sure. And it sounds like you might have an understanding of that. It typically comes in flares where kind of people get a gout flare and it's extremely painful, and so we treat those with kind of NSAID medications, things that are anti-inflammatory to try to help you through that process. Sometimes there's some steroid injections that are an option depending on what part of the hand or what part of the body. And then there's long-term medications if someone's having recurrent gout flares and it's just really holding them back and they keep running into that. Then there's some long-term medications doctors can put you on, like allopurinol, which can decrease your risk of a gout flare.
What kind of a doctor do you, the name of the specialist, what kind of a doctor do you need to see that specializes in gout?
I'd put that most within the subspecialty range of rheumatology.
Yeah, thanks, Gerald, for your question. And a reminder, we are talking about rotator cuff injuries or rotator cuff repair and management through surgery or with an orthopedic surgeon. So that's kind of what the topic of conversation is today. So if you do have a question, give us a call, 318-219-4569 to deal with rotator cuffs. So we have talked a lot about rotator cuff already, thanks to our callers, but we talked about the anatomy of rotator cuff, but what does the rotator cuff actually help you to do?
Yeah.
As far as like when your movement in the body.
Right. Yeah. So those four muscles each kind of contribute different things to shoulder motion, but that they all collectively contribute to shoulder stability. There's one that's just right in the front, one that's right in the back, and then two that come over the top that of these four muscles and tendons, and collectively they stabilize the shoulder and they prevent it from, they have a compression effect that kind of keeps the ball and socket kind of centered in the shoulder. Mm-hmm. And so that's why when you have a massive rotator cuff tear, it can lead to shoulder arthritis down the line, because the more motion, the more movement, the more opportunity for wear and tear in there. And so the first thing I'd say it does is it kind of promotes shoulder health by kind of allowing stability by all these doing their part. Mm-hmm. But then each one of them, depending on where they are, the more posterior one is an external rotator, the more anterior one, the subscapularis, is more of an internal rotator of the shoulder. Mm-hmm. And so it kind of gives you strength coming this way. But then the most commonly torn rotator cuff tendons, the supraspinatus and infraspinatus that come over the top, they're kind of these levers that when they contract are more responsible for, the supraspinatus for forward elevation. So that's why people have pain through this range of kind of right here. And then the infraspinatus is also some external rotation as well. And so they allow us to lift our arm without cheating, and kind of sometimes people come in and say that they can lift their arm up and then they lean this way and they shrug their shoulder and they use their deltoid. But the rotator cuff allows us to more elegantly lift our arm overhead.
Interesting. Yeah, and so it helps us to, full range of motion to achieve that full range of motion.
Correct.
But if one's not working as properly as it should, then you notice almost immediately, right? Or
Exactly.
you have that pain.
Yeah, so it's kind of pain and weakness are the two things. If we lose part of the muscle attachment, the tendon connection to the bone, that tendon might not feel very good. And also it's not attached anymore, so that muscle's down for the count. We can't, we're not as strong at whatever that muscle's supposed to do.
Yeah. And so a lot of times when you're thinking about a rotator cuff, we talked about this at the very beginning. Some people may think like, oh, that only happens to maybe athletes and these crazy injuries. But you mentioned over 40 is a time where you may see it more as well, but maybe because of the weakness, you think?
Yeah, I think there's a certain probably natural process to aging where the rotator cuff, I would presume the blood supply to the rotator cuff is not as good as we get older, and so there's a degenerative kind of wear and tear process that happens to where about 20% of people over the age of 60 have a rotator cuff tear, and that's significant because that means that there's just because you have a tear doesn't mean that you're going to have pain, and just because you have a tear doesn't mean you need surgery.
Right.
There's people who are coming into clinic to talk about their knee, and if we MRI'd all of their shoulders, a decent percentage would have a rotator cuff tear. That being said, you might say, well, how do we know it's a problem at all? Like, lots of people are living with it. Well, we've found that people who have some amount of tear, they're more likely to have shoulder pain, and when we fix them, when we treat them, they do better. So. We do think that it can be a problem for some people.
Right. Very interesting. Well, we do have another caller. Jim, thanks for joining us. And what is your question for Dr. Planchard?
Yes, good afternoon. I have been having some shoulder pain like for 6 to 7 months. And I went to my primary care, and by the way, I'm 70. And the radiologist report said that I had arthritis, and it's just one of my shoulders, by the way, which is not my dominant right hand, it's my left shoulder. So they just did an x-ray, they didn't do an MRI. And then something you said previously when you were speaking, you said that they diagnosed it as arthritis. But something you said that arthritis can lead to a tear. I wanted you to expand on that. And then if you were in my situation, I mean, I have full range of motion, but I'm pretty much constantly in pain. It varies from like a low level of 1, but it's really never getting above 4, I would say. More at night, like you kind of said, or when you're sleeping on it.
Yeah.
That shoulder. What would you recommend? I certainly want to prevent it, but can they tell that just through the x-ray that if it was torn or not?
Got it. Yeah, good question. So you can't you usually cannot assess a rotator cuff tear on x-ray. You can't see the rotator cuff on x-ray. The x-ray is just to look at the bones. You can see if there's a broken bone, or you can see if there's arthritis, and it sounds like that's what they've seen on your x-ray. And so basically on an x-ray, and that's the first place we start with a rotator cuff tear or someone who might have one. We're going to get an x-ray because we want to see if there is a component of arthritis to it, and I'll explain why that matters. But on x-ray, what they were probably looking at when they said that they saw arthritis is the space between the ball and socket that you can see has decreased potentially. There's supposed to be a certain amount of cartilage that is on the ends of the humeral head, which is the ball, and the glenoid, which is the socket. And when that cartilage is thick, it's healthy, it's there, then on x-ray that shows up as space between those two bones. And whenever the cartilage is worn away, you can't see the cartilage on x-ray, but you can see that space that's decreased. You can sometimes see that the bone looks hardened, or what we call sclerosis. You can see new bone formation called an osteophyte. All of these are signs that the cartilage is worn down. And the reason that matters is there's a certain amount of pain that comes from just lacking cartilage, and that arthritis pain, where the bone is banging into the other bone essentially without that cartilage cushion, and that can be a significant cause of pain. And so if you have a rotator cuff tear and you have arthritis, if we went in and we fixed your rotator cuff tear, there's not really a lot we can do about the arthritis arthroscopically, or like minimally invasively, or all the tools and tricks that we do to fix a rotator cuff tear. The arthritis is a separate problem that really surgically would just need to be managed with a shoulder replacement. And so that's why it matters at the start. If you think you're dealing with someone who might have a rotator cuff tear, you want to make sure that their x-ray looks really good, and that this is not an arthritis problem, that it's something that might just be limited to the rotator cuff, and if you fix that, you've fixed their problem. In your case, I would question whether I would want to see the x-ray and see does it look like, they might say arthritis, the radiologist might be doing a really good job and saying, hey, that's not a perfect shoulder, but in general, you look at it and you say, that probably shouldn't be causing a ton of pain from an arthritis perspective. And it sounds more like a rotator cuff problem, and you get the MRI and maybe you can just treat the rotator cuff. And then the last thing is a lot of radiology reports are going to comment on this separate part of the shoulder called the AC joint, the acromioclavicular joint, which is right next to the main glenohumeral shoulder joint. But they might say you have arthritis there, and that's just that's not an indication that you need a shoulder replacement. You could still be in rotator cuff repair world.
So if you were in my position, then, I mean, I've been living with the pain and treating it with ibuprofen or Tylenol. Would you let the pain dictate, or I can't make it, I'm not going to be making it worse by not doing anything, or you made a statement, or did I understand you to say that arthritis can lead to a tear? I certainly don't want to make it worse, so what would be your recommendation that one does, as we're describing?
No. So I tried to say that a massive rotator cuff tear can lead to arthritis, not that
okay,
arthritis
I got it
leads.
backwards.
Yeah.
I got it backwards.
And so as far as, if you have a little arthritis in the shoulder, what I would do if I were you is, if life is good, if you have a little bit of pain and it's not bothering you too much, or when it does, you take some Advil or Tylenol, they're very manageable and life is good, then avoid me. But if you're having more bad days than good days, then come in and see me or someone like me, and probably we need to try some other treatments like a steroid injection or some kind of prescription anti-inflammatory medication, some formal physical therapy. Again, all things trying to avoid surgery, but are a little bit more beefed up than just living with it or just hoping it goes away. And then if you stayed in that place where things weren't getting better, we'd get an MRI and see what the answer is and talk more.
Okay, thank you, sir.
Absolutely.
Yeah, thanks, Jim, for your call. We have just a couple minutes left. So really quickly, tell me a little bit about, if someone is wanting to have surgery or having those conversations with you. You mentioned that there's a good chance that a lot of people have a rotator cuff and they're unaware of it, but is it really when you want to start thinking about it, maybe when you have that pain and it's debilitating?
Yes, exactly. So like we were just talking about with Jim, you start on a process, and if it's more traumatic, if you fell somehow off of a ladder and now you can't lift your arm overhead, we're going to get an MRI day one, and if it shows a huge tear and you went from kind of great motion in the shoulder to you can't even use it, we're going to fix that one. We're going to go straight to surgery with that. We can give it a little bit of time, but I'm not very optimistic in that kind of setting that it's going to do well. Yeah. The long-term kind of wear and tear, or just some pain, just some weakness, we're going to try all that other stuff that is good, injections, therapy, medications, more time. But yeah, you want to start thinking about surgery once you've failed that and you get the MRI and you have a tear that's big enough to say, hey, we can go in and we think that's the problem for you. It fits your symptoms. That's a good reason for surgery as well.
Yeah, okay. And so if someone is, you mentioned having the surgery and, so this was my thought. I totally lost it for a second. But if someone is wanting to do the prevention measures, like the injections, the physical therapy, is that something that they could still come to see you?
Oh yeah, absolutely.
Yeah.
And I think that it helps to come to a surgeon who's capable of kind of doing A to Z, and if you need surgery, because they get to watch your progress. They get a really good sense of what you look like at the beginning and what you look like now. And there's some people so I'm happy to see people who don't need surgery and give them that good news, and I'm happy to see people who end up needing it because we have good answers. There's some people who come in and they want surgery, and you look at their MRI and you listen. They've been struggling with it for two weeks or something, and you try to push them. You say, hey, this, you could turn the corner. You might not need surgery here. And then some people really don't want surgery, and their arms hanging off their body, and you're like, I don't know if this is going to get better with a Band-Aid. But we do our best to try to give everyone what they need and what they want. Awesome.
Are you accepting new patients, and where can people find you?
Absolutely accepting new patients. They can find me at the orthopedic clinic at Willis Knighton. It's off Erie Drive across the street from Willis Knighton Piermont.
Awesome. Do you have a phone number that people could call as well?
They'll have to find that.
Okay, we'll just look up Kyle Planchard at the Willis Knighton, the orthopedic clinic.
The orthopedic clinic,
Yeah.
Kyle Planchard. Yeah, you'll track me down.
Google is our best friend. So awesome. Well, if you wanted to maybe rewatch this conversation, or if you were just tuning in and you didn't get to watch it, this will all be on our website at ktbs.com/podcast. Thanks, Dr. Planchard, and thanks for joining us.